I am so excited to kick off our STELLAR presentations today and to share with you my talk on pregnancy and spina bifida. So spina bifida is the most common non-chromosomal birth defect and results in neurological deficits that impact multiple organ systems, including the GU system. While spina bifida has historically been considered a pediatric condition due to medical advancement, those with spina bifida are now living very well into adulthood and thus are facing adult issues like pregnancy. But before getting into it, whenever I speak about individuals with disabilities, I like to just take a moment to ground the conversation in the social model of disability, which states that disabled individuals are variations of normal and opposes prior models of disability, which state that disabled individuals are broken and must be fixed. So just as a small example, I'm going to try to use language along the lines of differences instead of anomalies. But with that, I think this topic is really important because multiple qualitative studies have demonstrated that adult women with spina bifida are sexually active up to 80% and do desire to become parents, yet less than half have ever spoken to a provider about their sexual and reproductive health. And this has left a lot of gaps, both in the care that these patients receive, but also in their own understanding of their reproductive ability. And I think that urologists in particular are really well positioned to begin to address these gaps because these patients see us throughout their life, whereas less than half have ever seen a gynecologist. I think it's also really important for urology to be involved in this discussion because of the urological interventions we provide these patients. Neurogenic bladder is a major concern as subsequent renal failure is a leading cause of morbidity and mortality in this population. Luckily, we have a lot of tricks up our sleeves to try to prevent this from happening, but questions remain, especially about the surgeries, how it might impact conception, pregnancy, and delivery. And just to contextualize this a little bit further, I wanted to share a very recently published study by Lay and colleagues, which surveyed 270 adults with spina bifida. And in their cohort, which patients had an average age of 39 years old, and it was a predominantly female cohort, 70% had undergone at least one urological surgery, 40% had actually undergone up to upwards of 3 or more surgeries, and 72% catheterized intermittently, followed by another 13.4% who either had an indwelling catheter or a urostomy. So it's clear that this patient population, as a lot of us know, do have a significant urological surgical history. But again, that question remains of how does that impact how we think about conception, pregnancy, and delivery in this population, as well as how does spina bifida itself impact these things? Well, starting with conception, I wanted to share this retrospective cohort study by Shepherd and colleagues. They looked at the number of women with spina bifida who were conceiving and subsequently delivering over a 10-year period, and you can see that there's been a steady rise from 2003 to 2013 in the number of women delivering. And it's pretty clear across the literature that spina bifida has no impact on one's ability to conceive. But what is important to consider is folic acid supplementation, and not just any folic acid supplementation, high dose folic acid supplementation at 4 milligrams per day instead of what's recommended to the general public at 0.4 grams per day. And of course, we know that that helps to ameliorate the environmental contributions to future neurogenic neural tube defects, but a lot of qualitative studies have shown that this information is lacking in these patients themselves. Aker and colleagues conducted a qualitative study with 14 participants and found that of the women who were sexually active and of childbearing potential, less than half were taking folic acid supplementation. And when they looked at the themes for why this might be, a key driver was that they did not understand the role of folic acid. Another recently published qualitative study looking at 8 pregnancies from 6 women with spina bifida found that despite 5 out of 6 of them actually intentionally trying to conceive, only 1 was taking proper folic acid supplementation. So from this, we've learned that women with spina bifida can absolutely conceive, but what's most important is ensuring that they are taking the proper dose of folic acid prior to conception. When it comes to pregnancy, I wanted to first start out with this retrospective cohort study by Roth and colleagues, which evaluated 18 pregnancies from 11 individuals who had undergone some kind of lower urinary tract reconstructive surgery, 10 of whom had spina bifida. In terms of the surgeries they underwent, the most common was bladder neck reconstruction, followed by bladder augment, creation of a catheterizable channel, and then ureteroneocystotomy. In terms of urological complications that the patients experienced during pregnancy, of the 15 viable pregnancies, 10 were affected by new onset hydronephrosis, 6 of which were symptomatic and required nephrostomy tube placement, and then an additional 53% had difficulty catheterizing, both per urethra and catheterizable channel. So from this study, we've learned that the most common urological complications in this patient population during pregnancy are hydronephrosis and difficulty catheterizing. The last point I wanted to just briefly touch on for pregnancy itself is how we think about asymptomatic bacteriuria. Now, it is exceptionally common in this population because of them catheterizing and the surgeries that they've had. And generally speaking, in urology, we vehemently advise against treating asymptomatic bacteriuria due to concerns about antibiotic resistance. But things are a little different during pregnancy because of the very strong correlation between untreated asymptomatic bacteriuria and preterm delivery and low birth weight. So obstetric experts do recommend treating all asymptomatic bacteriuria, including in these individuals where it is possible that they will then be on it for the entirety of their pregnancy. So antibiotic prophylaxis may be needed for the duration of pregnancy in these individuals. Last, when it comes to delivery, I wanted to circle back to that article by Roth and colleagues looking at those 18 pregnancies from the 11 participants who'd undergone some form of lower urinary tract reconstruction. And 100% of their cohort delivered via C-section. What's interesting though is that 2/3 were completed emergently, and that to me explains the relatively increased rate of a midline skin incision, which has its own implications in terms of core wound healing, future hernia risk, and it also explains the relatively increased rate of a classical uterine incision, which has its own risk, including future uterine perforation, and actually prohibits someone from attempting vaginal birth in the future. In terms of intraoperative complications for their cohort, 40% experienced at least one complication, with the most common being cystotomy, followed by getting into the bowel and vagina with the uterine incision. So in this cohort where 100% of the participants delivered via C-section, most were done emergently, and the most common intraoperative complication was cystotomy. Because of this, there is a lot of discussion in the literature about potentially having a role for a planned C-section, depending on kind of shared decision-making between us, the patient, and their obstetric provider. The last study I wanted to share is by Shepherd and colleagues. It is a large retrospective cohort study looking at 9 years worth of data from 9,500 women with spina bifida who delivered over that time period compared to 38 million women without spina bifida who delivered, and they compared their obstetric outcomes. But before getting into that, I do want to just note some baseline differences between these groups. Those with spina bifida were significantly younger and were significantly more likely to have had a prior C-section. But ultimately, they found that women with spina bifida were significantly more likely to undergo cesarean delivery at 53% compared to 32%. And that women with spina bifida had significantly greater odds of experiencing complications during that C-section, with an odds ratio of 1.49. Of note, this did not reach significance when looking at vaginal delivery. And just like Roth and colleagues, Shepherd and colleagues found that the most common complications were injury to the urinary tract or GI tract. So women with spina bifida seem like they're more likely to undergo cesarean section, and they're more likely to experience complications during C-section. Therefore, it is recommended, especially for patients who've had reconstructive surgery in the past, that a urologist is present for the C-section. Now, that's all the data that I think I have time to share, but I'll leave you with, the data has limitations. Obviously, most of this was retrospective. Many of the studies were limited by small sample size on top of that. And even the larger ones were missing key variables to this discussion. And it's compounded by the fact that spina bifida is super heterogeneous. So in the future, it would be my dream if we could come up with some kind of large standardized cohort across all of our institutions so that we'd have the data to actually produce formal guidelines on this. But until then, these are the main points that I learned along the way. And I just want to emphasize that urologists have a really key role in promoting safe and thoughtful conception, pregnancy, and delivery, and that ultimately starting these conversations with our patients and understanding their reproductive goals is the best place to start. Thank you.
So when deciding on a topic for today, I wanted to think of some of the exciting moments ahead here at Yale, and I figured I wouldn't do another whole presentation. So today we've been on the Glue-Clot technique and extraction of renal stones that are difficult for patients. So we'll start with a patient that Dr. Khan and myself had operated on. This was a 59-year-old gentleman with a history of hypertension, diverticulosis, along with a complicated hospitalization, lasted 2 months for elective sigmoid resection, which was complicated by bowel perforation as well as septic shock. He ended up presenting to our ED about nausea, flame pain, vomiting, as well as hematuria. This was suspected for obstruction. So his significant past medical history, he had clinical illness, myopathy of his bilateral extremities. He had paralysis of both legs. He was a wheelchair user, 5'9" male, BMI of 31. So this is a non-contrast CT, which showed a 1.6 centimeter proximal left uretostone with associated mild left hydro and large left stone burden. So the plan for this gentleman, he was initially taken back for cysto and stent placement to relieve the obstruction. At the time, his CBC was normal due to growth protease species, which was multi-drug resistant, and he later recovered after a short hospital stay. Dr. Q planned a two-stage approach to relieve his stones due to his extensive stone burden. The first cysto went well. At the end of the operation, that no large stones were noted. On the second stage, this is an operation that I had planned the opportunity to take part in. Again, the same procedure, uroscopy related to the strictopsy. This cranium had stabilized 1.1, and the urine culture had again grown protease species. So, given his past medical history and comorbidities and his poorly draining kidneys, as noticed by his CT scans, Dr. Khan, Dr. Lemon wanted to relieve as residual stone dust as possible. The literature supports that residual stone dust acts as nidus for stone reformation, and that this is particularly true for infectious stones as well as cystine stones. So after lasering and basking for a period of time, Dr. Khan decided on the idea to inject blood into the scope to extract the residual stone dust. So this is known as the Glue-Clot technique, also known as coagulant lymphotomy. And so the steps for this, I'll go back a little bit. So originally published in 2008 and further published in 2014 as a step-by-step tutorial. The steps are to reduce the stones to 2 to 3 millimeters by dusting. You then assay on a guillotine for 10 milliliters of venous blood from the patient. You extract the blood, or you insert the blood into the working channel of the scope and allow the sole injector for a period of 5 minutes. You wait then 5 to 10 minutes, allow the blood to clot within the calyx, and then a basket's used to retrieve the clot. You can essentially use the clots to mop up the calyxes from the residual stone dust. So there are a number of considerable disadvantages that the study does mention, like decreased visualization as well as increased waiting time for clotting. But again, there are a number of published data on the increased stone-free rates by using this technique. So again, several studies also mention the use of this technique for extracting stones in the lower pole. The technical benefit is twofold. It allows more surface area to grab the clot, as well as more surface area to bind with the basket. And so they also note that stone retrieval is also accomplished in less passages, which minimizes the chance of ureal trauma. And thank you for Mona for that video. So one proponent of this technique also recommends leaving the lower calyx filled with blood to completely decompress the calyx. What they found is that comparing their retrospective analysis to other studies in a meta-analysis, that patients at a 3-month period using KV ultrasound, KV X-ray ultrasound, found that 90% of their patients had a stone-free rate when compared to 50 to 80% of other papers. And so now, considering our patient in the potential phase of renal dust and post-op, there's a variance in literature for the fate of renal dust. But the consensus is clear that leaving no stone is best, especially for patients with comorbidities. So the definition of stone-free is actually a controversial issue with varying papers define stone-free as the absence of stone on KV ultrasound, but new literature has been using CT scans to define stone-free rates. And this brings into question whether or not Randall's plaques qualify for a stone-free rate. So in this 2011 paper here, the objective was to determine the long-term behavior of stones over about a 2-year period. And so what they found is that about 77 to 81% of patients with renal stones experienced a stone-free rate, and 91 to 100% of stones had a stone-free rate. And so the intermediate definition of stones versus a stone-free is a clinically insignificant residual fragments, where the stones are less than 4 millimeters in size, asymptomatic, non-obstructive, as well as non-infectious. And so this definition has been called into question because about a third of these patients will actually experience a stone-related event within a year and a half. And they also found that there's an increased absolute risk for amount of residual stones left within the kidney. But particularly looking at this paper here, Natural History of Stone Fragments, they found about 1 in 5 patients, or about 20%, experienced astonament with a mean follow-up of about 28 months or 26 months. And they said that the rest of these patients either spontaneously pass their stone or retain a stone, with most of them located in the lower pole. So when considering stone fragments, another meta-analysis took a look at the rate of stone regrowth, and as you can see, there's a lot of variance in the data, with some studies saying at 30-month follow-up, there's a 2% rate of growth compared to other studies at 15 months at a 59% of growth. But it's also important to consider that these papers didn't necessarily take a look into account the stone type as well as the patient population, demographics, and so these are things that they seem to control for their analysis. So given our patients' comorbidities and also the important other factors associated with repeat procedures, we took a look at this 2022 systematic review, which highlighted considerable factors associated with repeat procedures. And so what they found is that multi-drug resistant urine holders were significantly associated with those needing, persistently associated with urosepsis and those needing repeat procedures with an odds ratio of 15. They found a positive linear relationship between operative duration and severe adverse events, including sepsis. High irrigation pressures, including use of a manual pump as well as use of syringe, was independent factors for urosepsis in 2 different studies. And patients that undergo uroscopy after stent placement were found to have a higher risk of postoperative sepsis. And this doesn't include the risk of anesthesia as well as EVT and perioperative complications. So the future of the Glue-Clot technique and making basketing more efficient has introduced a novel bioadhesive technology for stone fragment retrieval. So the substance you can see in the bottom right-hand corner is composed of cationic cross-linked polymers to optimize stone extraction. So in this experiment, they use a plastic kidney model as well as filled it with 156 milligrams of sand to simulate stones in renal dust, and tested their polymer with experienced and non-experienced surgeons, attendings and residents. And so they found that extraction of the sand was only possible using the polymer and with a stone-free rate of 84%. The mean time for experienced surgeon was 16 minutes compared to 22 minutes in the residents, and the stone-free rate difference was 79% for the experienced surgeons versus 86% in the resident group. And so now they're currently working on in vivo studies with animals, and where they intend to leave the polymer behind to see what are the effects in the kidneys over a long period of time. Importantly, they note that they are also doing studies to see what is the difference with the interaction of blood and urine when using this polymer. And so there's also new data on comparing the 2 coagulant lithotomy mediums of blood and this new polymer, as well as the control of not using anything. And what they found is that significant difference in retrieval time, as well as the number of tries used to retrieve stone dust. So compared to not using, or the control group, the polymer was able to extract the stones at a rate of 10 minutes compared to the blood group at 26 minutes and the control group at 36 minutes. The average number of tries was significantly lower in the polymer group at 8 tries versus the blood group at 22 tries and the control group at 27 tries. And so what they also noted as well is that within the blood group, if you allowed the blood to clot over the period of 10 minutes, the difference had essentially disappeared between the novel bioadhesive as well as the blood clot group. So just in summary, patients with residual fragments less than 10 millimeters, defined as clinically insignificant fragments detected by non-contrast CT, have about a 20% chance of a symptomatic stone requiring hospital at a mean of 19 months. The Glue-Clot technique is described in adult and pediatric case series and can be used to extract small stones that are challenging for basket extraction following laser lithotripsy, particularly in the lower poles. Novel bioadhesives and coagulant lithotomy have shown decreased operating time, scope passages, as well as maximized stone clearance. And further studies investigate the in vivo clearance rate of novel bioadhesive versus blood clot techniques, and also should consider its cost, safety, as well as operative time and complications. And this is for Amir and Jeffrey. Thank you.
Hi, my name is Dongmin Kim. I'll be presenting on improving access in urologic oncology to clinical trials. Disclosures, I got a small research grant from Rutgers for the current study that's going on. And so to start off, clinical trials are one of the most effective tools for research development, and they set the standards in which AUA and NCCN guidelines derive their guidelines off of. And from 2000 to 2011, 18% of cancer trials in the National Clinical Trials Network closed with fewer than 50% of the enrollment within 3 years of starting the trial. And it's important to note that more than 20% of the cancer burden in the US is actually urologic, but urologic trials are particularly vulnerable to poor accrual and accrue patients more slowly than other subspecialties. And especially going into urology, urologic oncology has the highest rate of trial failure. And as I mentioned before, urologic trials tend to accrue patients more slowly despite positive attitudes from practicing urologists. Also, more than 50% of trial eligible patients agree to participate in clinical trials, but and this suggests that it's actually organization factors, not patient refusal, that leads to the lack of patient accrual. And 80% of urologic cancer is treated in community settings. So one of the things that urology that's more urology specific is that decision to enter a clinical trial is often made made after the medical treatment has already been decided, and therefore that leads to lower accrual. And so in this presentation, we're going to look at two different retrospective papers that look at the characteristics of the urologic clinical landscape and then go into how to address those factors. And so the first paper that I looked into was a study that studied the characteristics and predictors of successful and failed urologic clinical trials. This looked at about 1,300 trials on clinicaltrials.gov, dates ranging from 2006 to 2015. And so what they found was that majority of the reasons for trial failure in urology was due to poor accrual. You can see over here that 41% of the reason for trial failure was due to poor accrual. And then also on multivariate analysis, the study also found that oncology was 2 times more likely, and infertility and andrology was 5 times more likely associated with trial failure. And so as a key finding summary, among the trials that failed, poor accrual was the primary reason for trial failure, comprising of 41 failures, and in trial failure was associated with oncology and infertility and andrology subspecialty. The second study that I looked into was access for urologist participation in research. This paper looked at 500 out of 900 cancer therapy evaluation program institutions, and this study looked at group survey data from the NCI Community Oncology Research Program in 2017. And you can see over here that 36% of oncology practice groups had no access to urologists for research, but even among those reporting access, the 63.6%, the authors mentioned that majority were not co-located with the urologist, which could present additional barriers to research as well. Another thing that this paper noted was that having hospital-based outpatient clinic and identifying as a safety net hospital were positively associated with research, but they had the main thing that they had looked at was oncology group ownership, and oncology group ownership was not associated. So the key findings was that 2/3 of the practice groups had access to urology practices, whereas 1/3 did not. And so this brings up the question of how we should address poor accrual and urologist participation in research. And one paper that I looked at was a review paper of 10 urologic studies and 26 non-urologic studies dating from 2000 to 2021. And this looked at, divided the interventions into 3 different types: patient-specific, provider-specific, and system-specific barriers. And so we'll look into those 3 specifically. And so to start off with the provider related, as we noted before, the barrier to clinical trial was poor accrual, showing the 41% of failures. Another study found 54% of failures. And another factor is that community urologists are less likely to report access to clinical trials than their academic counterparts. So on the right-hand side of the slide, you can see the ways that they have interventions that they have studied. And a study noted that urologists tend to have established referral networks that necessarily do not always include institutions that involved in clinical trials. The recommendations to address these problems were regular communication with the community practices, such as point of care flow sheets and flow sheets outlining ongoing trials. Another option was a hotline where urologists and patients can call to discuss the enrollment process. And another one was having workshops and continuing education where the community urologists and the academic, research institutions meet face-to-face and create increased trust and communication as well. The second factor that they looked at was patient-related, and the patient-related barriers, the main focus were financial as well as cultural barriers. A study noted that a study compared two patient groups, patients who were making about $100,000 and patients who were making about $20,000, and found that the patient group making $20,000 per year were 23% less likely to participate in the clinical cancer trials. Also, patient surveys reported that patients lack an understanding of the trial purpose as well as knowledge about the treatment and trial options. And to address this problem, they created culturally adapted recruitment cards, social marketing, and patient-centered communication strategy. And having cultural adaptations in the clinical trial marketing materials can have significant impacts. And there was a study that actually studied Asian American, did a trial where Asian Americans received a Pan-Asian greeting card with the traditional recruitment packets or marketing packets were 4.5 times more likely to enroll in those trials than those who were sent the trial packets alone. And lastly, for structural barriers, many oncology trials are conducted at NCI or institutions, but a few cancer patients are actually treated in these sites. And specifically for urologists, the credentialing process for their practice is a hurdle for referring patients. And most clinical practices are required to undergo an intensive administrative workload, which may be a barrier for community urologists. And for the possible interventions, offering patients a branded marketing and patients and referring physicians materials such as brochures can help with patient accrual for clinical trials, and these materials can help patients engage in conversations with their physicians, as well as decreasing the time burden that physicians face through presenting the material. Lastly, another factor is patient navigation programs where they directly reach out to the patients themselves instead of the referring provider, and this has been also shown to increase clinical trial recruitment. So one of the factors that they also looked at was telehealth as a possible option with the pandemic being a part of the end of the trial. And a randomized trial found that compared to face-to-face consent, telemedicine had similar rates of understanding of consent and accrual rates. So it is a possible option as well. And so in all, these are factors that can be implemented to help with accrual in our research, in our clinical trials. And one thing to note is that a study found that clinical trials with increased resources were more likely or less likely to fail. However, they found that not necessarily increasing the budget is, they found that the budget alone did not, lead to statistically significant increases in trial recruitment. And therefore, it's important to address these factors and look at ways of continuing to improve. So in conclusion, this is a multidimensional approach that involves inclusive methods for patient recruitment, patient-centered care, navigators, and increasing resources for providers and practices. Thank you.
Hi everyone, I'm Jada from UMKC School of Medicine. As Stephanie said earlier, I got my master's in science and clinical research this past May, and this was my master's thesis, self-efficacy in nutrition and exercise affecting long-term quality of life in patients with prostate cancer. So my study was a secondary study of a pilot clinical trial called the Warrior Trial. And what that basically was a weight management intervention designed for men who were scheduled for radical prostatectomy. Those in the intervention group, so about 20 men, receive one-on-one diet and counseling for nutrition and exercise for 5 to 16 weeks before surgery. And those in the control group only receive reading materials and brochures. And what the pilot trial concluded is that it worked. On average, those in the intervention arm lost an average of 5.55 kilos. And the SFA's quality of life scores in the intervention arm were significantly higher in the intervention arm compared to the control arm. And so what my study sort of tried to look at was the long-term quality of life and what were the mediators of that. So the objective of my study was to determine the correlation between self-efficacy for healthy behaviors and long-term quality of life in prostate cancer survivors in the extended post-operative period, and explore how social vulnerability may influence this relationship. So to break it down a little bit, self-efficacy is a psychological theory proposed by Bandura in the 1990s, and it's basically one's determinism and their ability to engage in any type of behavior. In this instance, it's healthy eating and exercise. And this psychological theory has been proposed to work and shouldn't be efficacious, not to say, in diabetic patients and other general surgery patients. And so I thought it would be a good application to prostate cancer patients, considering that it is a major pelvic surgery. And social vulnerability, as I'll get into later, is a very nuanced fashion in which to analyze quality of life, as I can't give a quality of life talk unless I talk about the psychosocial and the socioeconomic factors that is influenced by on a patient's specific level. And so here are our methods. You can see our inclusion and exclusion criteria. Like I said, it was a pilot trial, and so we had 40 patients recruited from the KU Urologic Clinic and the KU Cancer Center, and they had to have histologically confirmed clinically localized prostate cancer, scheduled for radical prostatectomy, and had a BMI of overweight to obese. And so this is the self-efficacy questionnaire, the actual one that I used in the study. As you can see, it's very much designed around the patient's ability to overcome daily stressors in order to achieve their healthy behaviors. And so I can eat healthy foods, even if I'm stressed, even if I'm sick, even if I'm on vacation and things like that. And this is the quality of life index that I chose to use. This is the quality of life in cancer survivors instrument from the online Phoenix toolkit. I like this questionnaire because it's broken up into 4 different domains: physical, psychosocial, spiritual, and social. The only item that I omitted from this questionnaire was item 7, which was about menstrual health, which obviously did not apply in this population, but all 3 of the tools were validated. So the primary outcome for this study was the strength of correlation in the regression line between self-efficacy and healthy behaviors and long-term quality of life. Because ultimately what this study tried to explore was, is self-efficacy for healthful behaviors a viable psychological mediator in long-term quality of life? And there was an exploratory analysis which was conducted examining the relationship between self-efficacy, quality of life, and the actual percentage of weight loss during the trial, and as well as stratification for social vulnerability. So before I go any further into the results, what is social vulnerability? It's a very cool index created by the CDC and the Agency for Toxic Substances and Disease Registry. And it basically takes into account 16 different environmental factors, so certain US Census tracts and American counties. And so things like income, education level, access to public transportation, low-income housing, so on and so forth. And basically, if you plug in a census tract number or a county zip code, it'll spit out a level of stratification of terms of social vulnerability. So low vulnerability, low, medium, medium, high, and high. And so this is a really cool index, and it was useful for me as a researcher because this is a pretty simple stratification that does take into account a lot of complex social variables. And so just to get into a little bit of the preliminary data that I was able to glean from this, this is the self-efficacy and quality of life scores between the original intervention and control groups. I was able to get a response rate of about 31 out of the original 48 participants, so about 78%. And as you can see, in this long term, on average, these patients were about 4.5 years post-op. There isn't much of a difference between their scoring between the 2 groups, and then we can imagine that because at 4.5 years after radical prostatectomy, most people are pretty much back at their baseline. And so self-efficacy, nutrition, and exercise and quality of life are pretty much the same between both groups post-op. But why are still some people still scoring higher than others? And that's what self-efficacy is trying to answer here. And so what I did is I took a simple linear regression model in between self-efficacy for nutrition and quality of life, and I did the same thing for self-efficacy for exercise. And I was actually surprised to get a significant result here. As you can see, there's a positive regression line, as well as a positive, I used the Spearman correlation coefficient because I'm not assuming that any of my data is quite parametric since it was a pretty small sample size. So there's a positive correlation and a positive significant regression line in between self-efficacy for nutrition and long-term quality of life. And we can see the same thing here demonstrated for self-efficacy for exercise. As you can see, the R squared in these models are about 20, it was 22%, here it's about 25%, and so that means that about 20 to 25% of the variability in the quality of life scoring can be attributed to self-efficacy, which is pretty amazing. Even though 20% is not the whole 100%, it's still a pretty significant chunk that's not clinically dismissible. And so here was our exploratory analysis. This is one part of our exploratory analysis. The other part was actually, we did that same linear regression between quality of life and the actual percentage of weight loss during the trial. And actually that wasn't found to be significant at all. And we'll get into that into the conclusions as well. And so here, this may or may not mean much because social vulnerability, as I said before, was stratified to low, medium, and high. And so I took a small sample size and basically made it even smaller. And so these significant findings here in the self-efficacy for exercise tiering, again, this is stratified in the patients that were in low, medium, high social vulnerability strata. May or may not mean something, but then again, that begs a higher question that's beyond the scope of this master's thesis, is like, what are the intimate psychosocial and socioeconomic variables that come into play in a patient with who's a prostate cancer survivor after surgery? And so it's something to consider. It's obviously nothing causal data, but something to further explore. And as Chloe mentioned earlier, and I'm kind of getting into my conclusions a little bit, it begs the importance of including a large, generalizable, and diverse patient population when doing these types of studies in order to make it the most generalizable. And so the strengths and limitations in this study, as I kind of got into before, was a small sample size, homogeneity. Again, this is from KU Cancer Center. There's only 31 guys from the KU Cancer Center. A lack of comparability between the data collected 4.5 years ago and data collected now. But the strength of the study was that I used validated instruments and proper randomizations of individuals in the parent trial. And I used all of my correlations and regression lines for data that was collected here and now. So I'm not comparing data that I collected now to data compared 4.5 years ago, because that's not very comparable. And so the big takeaways from this study, I wanted to stress the limited temporal effect of the surgical rehabilitation and self-management programs. The trials like the Warrior trial that get patients metabolically optimized and losing weight before surgery, they work, but in the long term, you can't rely on a trial that they were in years and years ago to influence their quality of life in the long term. There are other things that need to be considered post-op patients in the long term. Again, positive association between self-efficacy and quality of life. So now we know that there's some a moderate strength of evidence in that psychological theory that keeping patients engaged in their healthy behaviors 4, 5, 6 years after surgery is still going to play a significant role in their quality of life. And that social vulnerability plays a role in engagement in these self-management behaviors. And these findings were consistent with the results of similar studies. And so again, a consideration for future research, larger, more diverse sample size would help to explain why certain individuals have better long-term quality of life than others. So practical implications that we can implement in the clinic, we're addressing unmet needs at follow-up visits. So even years and years after surgery, there are still things that need to be addressed with these patients and to ensure that they're living at the highest quality of life possible, the promotion of healthy behaviors, and the formal assessment of social support if needed. This is something I actually wish I stressed a little bit more when I originally defended my thesis back in April. A lot of similar studies, Santamina, Whitley, those are researchers that have done a lot of research in self-management programs before major surgery. Stress that having adequate social support before, during, and after major surgery can play a significant role in their engagement and nutrition and exercise. A lot of the patients actually that were in the Warrior trial, I had the pleasure of meeting and talking to on the phone when consenting. And a lot of times they'll tell you, oh, well, my wife made all the meals. It was my wife that was encouraging me to exercise and eat healthy. And so that's something to consider every time we see these patients in the clinic post-op. Just wanted to thank my team, and I welcome any questions. Thank you.